everyone. Myself, Dr. Shweta Singh, and I shall be presenting on intravitreal clindamycin as first-line therapy in toxoplasmic retinochoroiditis. So, ocular toxoplasmosis is one of the most common cause of posterior uveitis in immunocompetent patients. It presents as a focal retinitis patch adjacent to chorioretinal scar associated with overlying vitritis. Vision is usually affected with the involvement of optic nerve or macula or in the presence of severe vitritis. Conventional treatment involves sulfadiazine, pyrimethamine with folinic acid, trimethoprim, sulfamethoxazole tablets, azithromycin and atovaquone have also been used. So I'll be presenting a case series in which intravitreal clindamycin was used as a first-line therapy for toxoplasmic retinochoroiditis. So we report 4 patients of the diagnosed cases, 2 males and 2 females. All patients received intravitreal injection in the dose of 1 milligram per 0.1 ml as a first-line therapy along with oral corticosteroids, which were tapered over 4 to 6 weeks. So case number 1 was a 40-year-old female. The fundus picture shows active foveal retinitis. Best corrective visual acuity was reduced to finger counting 1 meter. The corresponding OCT shows significant macular edema. The patient got 2 injections of intravitreal clindamycin, and this is the post 2-month picture showing resolved macular edema along with restoration of BCVA to 6/6. Another case, a 12-year-old male who presented with juxta macular retinitis, best corrective visual acuity reduced to 6/18. This is the post-month picture, the fundus picture and the OCT, almost coming down to normal. Case number 3, another 52-year-old female presenting with focal foveal chorioretinitis, best corrective visual acuity reduced to finger counting half meter with significant macular edema and retinitis as shown in the fundus picture along with OCT. This is the post 2-month picture showing almost resolved retinitis patch and foveal contour restoration. Another case, this is a 22-year-old male who presented with a macular sparing retinitis patch. This is the picture post 1 month. So why and where to use this intravitreal clindamycin? Because high concentrations are reaching, it has a direct action on the target site and there is no systemic side effects associated. Where they can be used? In presence, if the patient has allergy to the systemic medications like sulfa-containing medication, in presence of intolerance to the oral medications like pyrimethamine can cause leukopenia or thrombocytopenia, when patient is intolerant to oral clindamycin with associated risk of pseudomembranous enterocolitis, wherever we are experiencing worsening or no improvement despite systemic medication, or wherever there is non-availability of pyrimethamine. Also, literature has also supported the use of intravitreal clindamycin. We came across few studies in which dexamethasone was also used, but in our patient we used only oral steroid in the dose of 1 milligram per kg per day. Then, conclusion, intravitreal clindamycin is equally effective for toxoplasmic retinochoroiditis. It is safe, efficacious, it has got better patient compliance and improved systemic safety profile. It has enhanced availability at the target site. We need lesser follow-up visits and less hematological investigations, and it can also be used as a better choice for treatment in pregnant females and pediatric patients. However, clinical studies are needed to validate the efficacy and safety in such age group and in pregnant females. A word of caution, we came across 2 cases in which they have reported the macular infarction, which was an aminoglycoside-like toxicity, which occurred in patients with intravitreal clindamycin as a treatment. So we recommend timely review and follow-up to detect any early signs of worsening. Thank you.
Thank you, Dr. Shweta.
Thank you, sir.
Any questions anybody has?
So we know that it responds very well to intravitreal clindamycin. Why we all prefer combining it with systemic therapy is that there's a very high chance of recurrence. So that is the main purpose of giving it, and that is why as a first line, of course, for macula involving lesions, it's very much the first line of therapy. But in the long term, we have to be careful that a recurrence rate is very high.
Well, ma'am, these 4 patients are in a regular follow-up. We haven't came across any recurrence in these 4 cases, but yes, whenever we are planning intravitreal clindamycin, patient should be asked to come in regular follow-ups.
And another important indication would be a pregnant female,
Pregnant female.
where
yes.
systemic therapy is contraindicated.
Yes, ma'am. See.
So how frequently did you give the intravitreal clindamycin between the patient?
Sorry?
How frequently did you give? Like it was a single dose or 2 or 3 doses were given?
Sir, this was a case series. We gave 2 doses. The duration between the 2 doses were 1 week. And after that we are following. We don't give as frequent. If the patient is tolerating the oral therapy, then we continue with the oral therapy.
And how long was the oral steroid given?
So oral steroids were given for at least 2 months, around 6 to 8 weeks for all the patients.
Can we combine this intravitreal clindamycin with dexamethasone?
Ma'am, in our series we haven't, but yes, we came across few case reports as well as a large series in which they have used dexamethasone. But we did, because we have to support the patient on steroids, so we gave oral steroids.
So the recurrence of toxo doesn't happen in every patient, but when it happens, it can be very bad. And sometimes there's also a description of a prophylactic or a maintenance dose of clindamycin, which can be given to the patients, and they may be requiring a treatment even for a year or longer.
Okay.
So that is why I think systemic therapy is equally important as much as is the intravitreal injection.
Noted, ma'am. Thank you so much.